I forgot how long these go. And I reached out to Nicole and I was like, how long? Because this could very easily be a 3 hour discussion from me because once I get launched into this, sometimes it's hard to get me to stop. The good news is Jamie and Nicole both have mute buttons. Um, Nicole said, well, if you make it interactive, you can go over 15 minutes. And so I looked at it and it would be a reach to make it interactive. So I'm going to try to talk really fast to get through this. But if you want to interrupt me at any point, unmute yourself and ask a question and then make it interactive. We can go longer than that. Um, this is going to be a very quick overview. And if you're somebody who uses the ASAM tools fairly often, this will be um, a little bit too introductory. But if you're not familiar with it or just adjacently familiar with it, hopefully it'll give some reminding ideas or at least some introductory ideas. To start out, I need to mention that neither I nor my organization are directly affiliated with ASAM. The didactic, the slides not intended as or only intended as introductory education about the conceptual framework, a little bit about multidimensional assessment, not too much, and some introduction to levels of care as they're defined by ASAM. So it's not, I'm not claiming to prepare you nor certify you in the use of ASAM. So there's my disclaimer. Why ASAM? Why do we talk about it? What's the utility of it? Well, ASAM stands for the American Society of Addiction Medicine, and among the things that they do, probably the most recognized, they've developed pretty extensive treatment criteria for helping to understand where folks with really any level of substance use involvement and that's my language, not theirs. Their language would be with addictive behaviors. Um, in understanding and conceptualizing, and then also understanding where they are in terms of level of need and what the appropriate matches would be. This is kind of damning with faint praise from me. It's really well developed, and it is really useful if you dive in with both feet to it. If you use it very superficially, like a lot of folks, I think do because of the requirements, then the utility is pretty much lost. So we're discussing it because it is a nice way to provide pretty well recognized standards of understanding uh, conceptual needs for folks, and then also probably most especially and most recognized for making level of care decisions or justifying level of care decisions. So that's at a national level, but certainly at a state level, it's nice to have the ability to compare apples to apples. You know, for so long we've kind of each organization, each agency has developed its own conceptualization tools and its own method of understanding. And then if you are coordinating care as you're referring somebody to another place, to another connection, or trying just to understand folks that you're working with from agency to agency, from place to place, that makes it very difficult. And so this standardization certainly increases the ability to everybody being on the same page. In addition to that, that bit of benefit, it's also required in Ohio for any level of intentional substance use work. If you're familiar with the different codes, there's the Constitution, and then there's revised code, and then there's administrative code. And so this is laid out that if we're doing any kind of addictive work, really just around level of care placement decisions, we're required to use the ASAM conceptualization and tools. So I'm not going to go through the stuff that I've highlighted in here to talk about. And Nicole, I never sent you these slides, but I'll send you these so you've got them so you can post them. So you can refer to that if you'd like to. In addition to the requirement at the state level, if you're providing treatment with any kind of intentional inclusion of addictive work, we are required to be using ASAM. Today, I'm talking about and considering treatment for youth, which always not always, but should always involve families. The if you're involved in Ohio Rise, if you're familiar with the Ohio Rise initiatives and then the related services with that, the CANS relies on getting folks enrolled into Ohio Rise, and then there's other services even outside of Ohio Rise in Ohio now that we're using the CANS, which also provides a nice standardized, person-centered, person-focused understanding of different areas of strengths and needs for kids and families. Of all the items in the CANS, if you've seen it, there's up to at least 135 items that can be measured in the CANS. One asks about substance use. And on that one item, if it is rated as a 1, 2, or 3, there's a 4-level rating system, so there's only one number left out on that. If it's rated as a 1, 2, or 3, there is the recommendation that that person be referred for an ASAM assessment to increase the understanding of what's going on, and then also to inform level of care. So there's a lot of connected, related requirements and expectations about using ASAM in the state, especially. I don't know if it's fair or not to say, especially for youth. My focus is youth. Um, but with the inclusion of the Ohio Rise and maybe some FCFC and wraparound kinds of things that would be involved with the CANs, I'm going to say, especially for youth. Thinking about youth, if you're familiar with ASAM, but you don't work with youth, then you may be familiar with the newly released fourth edition, which is pictured there on the left. Um, in the fourth edition and their new scheduled release and releases, moving to the fourth edition, they have now moved to separate treatment for youth and treatment for adults. And they released the adult edition, it's been about a year ago. So it was released just about a year ago for adults. They are in the process of updating and finalizing the edition for adolescents. And it was scheduled to be released at the end of this year, but where they are in the process, it's not going to be until next year. Um, so the fourth edition, which will be specific to adolescents, will be released sometime next year. And then interestingly, they're also expanding with a plan to include focused volumes covering addiction treatment in jails and prisons sometime late next year, and then the year after that. And I'm kind of looking forward to this one. I like to see how they conceptualize this. In addition, specific to behavioral addictions. So, talking about youth today, we're still considering the third edition. It's structured the same, very similarly to the fourth edition. So, if you're serving youth, you will still be using the third edition. And even if you're serving adults, you can still be using the third edition. There's no requirement that we use a specific edition. So. In the third edition, though, which came out in 2013, ASAM was very intentional about considering adolescence differently, which was a really refreshing change. So often things that are designed for adolescents, and it feels like, I don't know if this is completely accurate, but it feels like, especially in the drug and alcohol field, things that were designed for adolescents were taken from adult models and they were just backed up and placed on adolescents without an understanding of what's very different in that developmental period of life, and how the match by just backing things up very rarely worked. And so ASAM, over 10 years ago, was cognizant of this. And in that third edition, they separated considerations for adults and adolescents, and they were very intentional in that. So coming from the very start of that text, they mentioned adolescents must be approached differently from adults because of differences in their stage of emotional, cognitive, physical, social, moral development. Also mentioning adolescents typically demonstrate higher degrees of co-occurring psychopathology, which may not remit with abstinence. Not a huge fan of psychopathology terminology applied to adolescents because of the plasticity and the possibility for change there. And that's almost damning from my point of view. But I am heartened by the mention of this. And certainly with adolescents, I don't know about increased psychopathology, but there is an increased risk about opportunistic and bingy use around drugs and alcohol that are different from adults. And so maybe not a fan, not a fan of the terminology, but certainly the intent behind it makes a lot of sense. And then also they mentioned they typically require more external assistance, more external motivation, because part of the difference with that period of life is, every adolescent is immortal, right? There's an intellectual understanding that these risks could apply to others, but there is not necessarily that internalized application of that understanding. And so external motivation is even more helpful in working with adolescents. And so incorporating that as part of the consideration, and really part of the consideration about where they are and their readiness to consider change, which then gets very complicated. They're not talking about that here, but it gets very complicated, but considering readiness for change in adolescence, which is addressed by ASAM a bit. There's the consideration of where the kid is in readiness to consider change, but then there's also where the family is in readiness to consider change. Typically, they're ready for the kid to change, but they're not necessarily ready for the family system to change. And so there's a lot of interlocking pieces there, mutually influencing pieces. So this steps out of what you may expect in a discussion of ASAM, thinking about, well, I want to hear about the dimensions and how you rate risk and then how you make level of care determinations. I think equally important with that part of the tool, this is, my take on this, but equally important with that was their description, which started in the second edition and then they updated it in the third edition, where they identified program readiness to provide care to folks with co-occurring needs. As soon as any level of substance use need is identified in an adolescent, there's over a 70% chance that there is a co-occurring mental health need and then a family system need that goes along with that. So over 70%. The higher the degree of needs and involvement with substances, the higher those percentages go. And so it's not just an expectation, it's even beyond that. So the ability to provide co-occurring care is extremely important. And they provided descriptions starting all the way back in 2001 with the second edition. They identified 3 different levels of programming readiness. And back then, at the turn of the century, they identified programs that were addiction only ready. So that would be a drug and alcohol program that would only provide drug and alcohol care. When I started as a therapist, I started in a drug and alcohol clinic. We were only allowed to operate out of one chapter in the DSM-3 at that time. And it was just drug and alcohol stuff. And that was it. We couldn't touch anything else. And so that was an addiction only service. By 2013, in the third edition, they updated this and they said no program should provide, such siloed care that you're only going to touch one area. So they said that every program, whether you're talking about an addiction-focused program, a mental health-focused program, they should be able to provide at least some level of recognition and integration. And so they said the baseline expectation is you should be able to provide co-occurring capable care. That's not advanced kind of stuff. You're still going to specialize in one side or the other, but that's the co-occurring capability baseline expectation that they set. And that was in 2013. And it appears that, well, and from the adult edition, they're retaining this terminology in the fourth edition. So they said true for any type of program is defined by the mission, the resources, all the way up through the training. That co-occurring capability involves integrating at every level the concept that the next person coming through the door can have co-occurring needs. They also mentioned kind of recognizing that programs are going to be hesitant about this, that, well, this is outside of our scope. Well, if you're providing care to any adolescent, if you've got more than 3 on your caseload, at least one of those has substance use involvement at some level, at statistical probabilities. So if you're not addressing it, if you're not acknowledging it, then you're not providing any kind of holistic care and you're decreasing the odds of successful movement and increased safety. So the expectation is that you should at least be able to recognize it and include it at some level, probably more of a superficial level, but you can include it at some level. And so that's the baseline expectation. Beyond that, and I'm not going to go through these, I'll send this so you can take a look. Here's their basic expectation levels at the co-occurring capable level. They define 2 levels above that. There's co-occurring enhanced. These are special programs, they say, that are more willing and they're more ready to provide care for more acute needs on both sides at the same time, not just one side. Like, we're a drug and alcohol clinic that can include mental health treatment or vice versa. It's we can provide care almost regardless of the level of need, one-stop shop kind of thing. That's co-occurring enhanced. Then at the very highest level, they also recognize that there are programs that achieve complexity capability. And these are programs, and the way they defined it in ASAM was, is this is recognizing in the real world, people are not as simple as, that's an intentionally ironic statement, they're not as simple as we can just boil them down to mental health needs and substance use needs. What else is going on at that time? I'm biased thinking about youth, and so I'm going to say, especially for youth, because if a kid has mental health needs and substance use involvement going on, then what else is included? Certainly, there's going to be family needs, probably school needs. There could be juvenile justice involvement. There can be, community involvement sort of things, and all of these interactive involvements. And so the more of these different areas of complexity that we can include and address all at the same time, the greater the likelihood that that kid and that family are going to stay engaged and they can benefit from the supportive services. And so the more that you can do that with high levels of intentionality and connection, then the more you can move towards this complexity capability, which really increases the odds. At the core, everything comes down to keeping them engaged, because if you don't have them engaged, then you can't provide any kind of support. So the complexity capability, if you're familiar with programs across the states, IHBT is a state recognized service, stands for intensive home-based treatment. And then there's some specialties within that. There's ICT, there's MST. MDFT does a nice job. These are very intensive programs that work with kids and families that very intentionally address the complex interactions. So that would take those to the complexity capable levels. You might be familiar, maybe you heard of the DDC tools. These were produced by SAMHSA, and I forget where they started. It might have been Cambridge. Um, Based on those types of definitions about co-occurring capability, where programs could, it's a self-rating, but you need an outside expert to come in and help you with it to figure out where you are in your ability to provide co-occurring care. They were based in the second edition, so they started out with addiction only. So they started very early, and they used the language kind of from the turn of the century. But programs find them very, very helpful. In my organization, we updated really as an adult-only focused tool that folks try to back up and use for adolescents. It's just not a good fit. But we updated it so that it was consistent with language in the third edition of ASAM, and also so that it had the developmental accountability, um, developing the co-occurring capability in youth treatment indices. And so if you're in a program that's interested in taking kind of a self snapshot and understanding where you are in your ability to provide co-occurring services, there's a tool to help with that. So if you have ever used ASAM, this might be as far as you've gotten, which is kind of a one-pager with the 6 different dimensions of care. And then there's risk assigned to those, and then treatment decisions are probably not made, but justified with this one-page tool. And if this is as far as somebody goes, not really using the full multi-dimensional ability to organize understanding of what's going on for somebody using these 6 different dimensions. I'll cover those in a minute, and then I'll wrap up if you're getting nervous, Nicole, that I'm going too long. If this is as far as you get, just a one-pager, there is a temptation, and I'm not saying that I did this in the past. I'm saying I knew of somebody who looked a lot like me that did this in the past, that there's a temptation to already know what your decisions and understandings are about the person that you're serving. And then because this is required to be used, in the old days, there were DATA's levels of care that were based on this, if that rings a bell with anybody. You'd already have all your decisions made. And then because this tool was required, you'd fill it out afterwards. So when you use it in reverse like that, there's no utility to it whatsoever. It's just a justification tool for billing purposes, and that's all there is to it. ASAM, with its very complex abilities for conceptualization, understanding, risk assignment, and then treatment match, one decision at a time, can be very beneficial, but it does have to be used to its more full extent. Just want to mention very quickly, if you're not familiar with working with adolescents, or if you are very familiar with working with adolescents, either side of that. If you go to NASAM, the National Academies of Science, Engineering, and Medicine, you have to join. It's free. You can download this, my favorite publication that is very specific to this period of life, in a distilled version, all packaged together like I haven't seen before. So it's several years old at this point, but still very useful. So the promise of adolescence, I recommend to everybody who provides any kind of care involving adolescents. So ASAM asks us to complete a very comprehensive assessment with the person that we're working with adults or with adolescents, and then organizing that understanding by these 6 different dimensions, which include the person's risk for, are they intoxicated at the time, or what's their risk for withdrawal afterwards? Is there any kind of risk that we assess with that? Dimension 2 asks us to take a look at influencing biomedical condition, not just influencing, but any, and then we're going to consider influencing afterwards. Any kind of medical conditions. Dimension 3 is a very large catch-all. It is any kind of mental health, any kind of developmental disability, and any kind of trauma. And with almost anybody with recognized levels of substance use needs, it's not uncommon that all 3 of those are going to be captured. And that is, I wish that they would expand Dimension 3, but we capture a lot in Dimension 3. Dimension 4 in the 3rd edition asks us to consider readiness to change. And it's nice to have that done intentionally. They changed it in the 4th edition. If you're working with adolescents, you're still working out of the 3rd edition, that would be where you would be capturing that. Dimension 5 asks us to look at relapse or continued use risk, or what are the continued problems that we can anticipate for this person. And then Dimension 6 looks at the recovery and supportive environment, which takes on a special level of importance when working with adolescents. In dimensions 4, 5, and 6, they also ask us if the person has identified co-occurring needs, mental health, substance use at the same time, to rate mental health and substance use separately for readiness to change, continued problem potential, and environmental community or family support. So to take a broader view of that. Each one of these has, well, not each one of these, Dimension 3 has some sub-dimensions of consideration, and there's increased complexity in each of these. But as you capture a lot of information about somebody, and you're thinking about a youth and the youth's family and their use and their mental health, and then you organize the information by these 6 different dimensions, it allows you to conceptualize what's going on in each of these dimensions separately, but then it also gives you the ability to consider the mutually influencing impact of each of these dimensions on each other. Some of those influences can be problematic or increasing risk. Like if, well, I'm not going to go through examples because I know I'm running out of time. But they can also be protective as well. So it doesn't just have to be risk increasing. Once we do a full assessment, we organize information, then we're going to assign risk in each one of those dimensions. And I didn't even put that up. Risk assignment is pretty straightforward. But once we do that, then we can use their different levels of care where they outline the expectations of what would be involved at these different levels of care. Level 1 is an outpatient level. Level 2 is an intensive level, which could include either IOP or partial hospitalization. And then levels 3 and level 4 are different levels of intensity and specialty in residential treatment. I'm not going to go through those. That would take forever. But when I send the slides, if you're not familiar with these, you can take a look at these so you can become familiar with those. There's also going to be a link here. This is specific to the 3rd edition volume. So this would be for adolescents currently. This was produced by ASAM, and you can link this through, I think it's through through Aetna's site that walks through in greater complexity those areas that I just touched on. So there's a very whirlwind tour of ASAM, really specific to considerations about adolescence.